Welcome to our video on histoplasmosis, blastomycosis, and coccidioidomycosis. Here are the topics that we're going to discuss in this lecture, and before we get to the actual organisms and the infections that they cause, let's introduce what all of these have in common. So histoplasmosis, blastomycosis, and coccidioidomycosis are systemic fungal infections, and each one of those infections is caused by a dimorphic fungus. And what this means is that it forms a mold in soil, but then when it's in tissues, it's a yeast. The only exception to that rule is coccidioides, and that actually forms spherules in the tissues. So again, mold in soil, yeast in tissues, unless you're coccidioides, and then you form spherules in tissues. And these fungal infections are transmitted by inhalation of spores. And there's no interpersonal transmission. So you don't get histoplasmosis and then transfer histoplasmosis to your family, your kids, or anything like that. And there's basically two clinical syndromes that you need to know about all three of these. That is, they cause pneumonia, and they can cause disseminated infection. With that background, let's go into the first topic, histoplasmosis. And as we go through this, we'll talk about the definition, clinical features, diagnosis, and management. So histoplasmosis, again, is a fungal infection, and it's caused by the fungus Histoplasma capsulatum. And it's most endemic in Ohio and the Mississippi River Valley. And the infection is associated with exposure to bird or bat droppings. For example, if you're exploring caves or something like that, and under the microscope, histoplasma appears as yeast within macrophages. And there's that idea of it being dimorphic. It's a yeast within tissues, including macrophages. And here we see an image of the United States of America. We'll use it to identify the endemic regions of histoplasmosis. So we already mentioned that it's most commonly endemic to Ohio and the Mississippi River Valley. And if it's endemic to those regions, then it makes sense that surrounding states could also be affected, including Illinois, Kentucky, and Tennessee. So how does it appear? Well, most affected patients are asymptomatic. However, symptomatic pulmonary infection, if it occurs, is usually mild, and it would present with a fever, headache, cough, and chest pain. And as we mentioned earlier in this lecture, with all three of these different fungal infections, they can cause a pulmonary infection, or what you're more worried about is a disseminated infection. And the disseminated form of histoplasmosis is typically associated with impaired immunity against intracellular pathogens. So the type of people that you think about are those who use glucocorticoids or TNF-alpha inhibitors, or HIV-infected patients who have a CD4 count less than 100. So that tells us who's at risk of disseminated histoplasmosis, but it doesn't tell us how it actually presents. So let's talk about that now. The clinical features of disseminated disease include weight loss, cachexia, fever, chills, and then mucocutaneous features such as ulcerative lesions on the tongue or the palate, or even erythema nodosum. And I'll show you a picture of erythema nodosum in a minute. But these patients can also have reticuloendothelial features. Basically, you're thinking of the spleen and the lymph. So these patients can have hepatosplenomegaly or lymphadenopathy. So this image shows erythema nodosum, and you can see those encircled nodular skin lesions. Those are classically on the shins. So you've got this sick patient. Now, how do you diagnose them? Well, on chest radiography, focal patchy or nodular infiltrates, as well as hilar or mediastinal lymphadenopathy, are usually detected in symptomatic pulmonary disease. On the other hand, that pulmonary imaging, if it was in a patient with disseminated disease, would show those nodules, but they'd be more reticulated, and you would see more interstitial infiltrates. And when it comes to disseminated disease, laboratory findings include pancytopenia, elevated serum alanine aminotransferase, so ALT, and aspartate aminotransferase, AST, and elevated LDH and elevated ferritin. But those tests don't necessarily tell you that it's histoplasmosis specifically, but they're logical tests to get in a patient with systemic infection or systemic signs of infection or pulmonary symptoms. And that makes sense. You'd get liver function tests, you get a chest x-ray, and things like that. But once you suspect histoplasmosis, you want to get a urine or serum-specific histoplasma antigen test. And that's the best place to start. And then microscopy with silver stain and cultures of specimens, such as a bronchoalveolar lavage or even a tissue biopsy on Sabarot agar, can be considered as well. But the idea here is just to think, well, if you're thinking about histoplasmosis, you're not going to go right to a culture of a biopsy. You're going to start with an antigen of histoplasma, which you can easily get without an invasive procedure if you test the urine or serum. Then once you've done that and identified the antigen, you can confirm it with microscopy or cultures. Now let's look at this microscopic image. This is taken from a patient with histoplasmosis. And note those intracellular histoplasma yeasts. Again, this is a dimorphic fungi, so it's a yeast in tissues. And here's a chest x-ray of a patient diagnosed with histoplasmosis, and it shows the bilateral pulmonary infiltrates. And if you've seen a lot of chest x-rays at this point, then you can see that this isn't super specific. It doesn't jump out at you that this is histoplasmosis. But the idea here is just to see that this is a pulmonary infection. And here's another chest x-ray that we can use to see hilar lymphadenopathy. Okay, so let's say you've diagnosed your patient with histoplasmosis. How do you manage it? Well, most infections of histoplasmosis are self-limited and they don't require antifungal therapy. However, in mild pulmonary histoplasmosis, that is if it persists for 4 weeks, then itraconazole can be used. And then you can also use amphotericin B, but that's reserved for severe disease. In other words, if your patient's vitals are totally stable and they're feeling okay, then there's no need to jump to amphotericin B. Now, when it comes to disseminated disease, amphotericin B or itraconazole should be provided. So the idea here is that you don't need to treat them with anything if they're mild and it's just limited to the lungs. And then if it's severe or disseminated, then you're going to want to get serious about itraconazole and even amphotericin B. Let's now go on to the next topic, blastomycosis. Blastomycosis is defined as a fungal infection caused by Blastomyces dermatitidis, and the endemic regions are the southeastern and central United States and the Great Lakes, so in states like Wisconsin. Under the microscope, Blastomyces appear as broad-based budding yeasts. Now here again is the map of the United States, and we can see the endemic regions of blastomycosis. And those regions are really similar to those of histoplasma. However, blastomyces extends a bit further to the north to encompass states like Wisconsin, Michigan, and Minnesota. So you're thinking more about that Great Lakes area. Now, most infections of blastomycosis are asymptomatic. However, symptomatic patients may have pulmonary disease, and that can be acute or chronic. Now, chronic pneumonia is a more common presentation, actually. So in these instances, the patient will usually present with a low-grade fever, chest pain, productive cough, and even weight loss. So that was pulmonary disease. Now, extrapulmonary disease from blastomycosis results from hematogenous spread of the fungus, and that actually has multiple manifestations. So when it disseminates to the skin or involves the skin, then verrucous or ulcerative lesions, as well as subcutaneous nodules are seen. When bones are affected, osteomyelitis and lytic bone lesions can usually result. And when the genitourinary system is affected, prostatitis or orchitis may occur. And when the CNS is affected, meningitis and epidural or brain abscesses can occur. And it's important to note that disseminated disease of blastomycosis can occur both in immunocompromised and immunocompetent patients. And that's a little bit different than what we saw with histoplasmosis, in which it was mainly in those immunocompromised patients. So again, disseminated blastomycosis can happen in healthy or unhealthy people. Here's a patient with blastomycosis. You can see these nodular skin lesions and also a bulla on top of one of these lesions. So how do you actually diagnose blastomycosis? On chest radiography, alveolar infiltrates may be detected. Now there's no hilar lymphadenopathy, and that can actually help distinguish blastomycosis from histoplasmosis. So histoplasmosis, yes. Hilar lymphadenopathy, blastomycosis, no. And microscopy and cultures of specimens, for example, the sputum or urine specimens, should also be performed. And here's a microscopic slide that shows broad-based budding yeasts of blastomyces. So let's understand what broad-based budding means. So here you can see the parent yeast, and then here's the bud. And you can see that the bud is attached via a broad base. So the offspring and parent are connected with a broad base, not a narrow stalk. So once you've diagnosed it, how do you manage it? Well, most patients will require antifungal therapy. And that's another thing to contrast to histoplasmosis, in which most patients don't require it unless it went on for 4 weeks, it was really severe, or it was disseminated. But in the case of blastomycosis, you're pretty much going to give antifungals to every patient. But the question is then, which one do you want to give? So for mild to moderate infection, you would give itraconazole. And if it was severe, you would give amphotericin B. So now let's do a quick question. A 40-year-old woman presents to the office with low-grade fever, non-productive cough, and chest pain. Physical examination reveals tender nodules on bilateral shins. Chest x-ray reveals hilar lymphadenopathy. The patient has lived in Mississippi all her life. What is the best next step in management? Okay, so our patient complains of fever, a cough that's non-productive, and chest pain. And erythema nodosum is detected on physical exam. And that was described because of those tender nodules on bilateral shins. And she lives in Mississippi, and that makes us think of histoplasmosis or blastomycosis. So those should be at the top of your differential. However, hilar lymphadenopathy that's seen on x-ray actually points more towards histoplasmosis, because we know that hilar lymphadenopathy is not typical of blastomycosis. So the next step in management is testing for urine or serum histoplasma antigen. And if that came back negative, then you would start considering other causes. Lastly, let's discuss coccidioidomycosis. Coccidioidomycosis is defined as a fungal infection caused by Coccidioides immitis. And the endemic regions are the southwestern United States, and we're thinking really Arizona and California. And it's strongly associated with exposure to dust. And that makes sense, considering we're referring to the southwestern United States, where you would see more dust or get exposed to more dust in the desert. And under the microscope, coccidioides appear as spherules filled with endospores. And just to drive this home visually, here's a map of the United States one more time. Let's identify the endemic regions of coccidioidomycosis. So again, we're thinking southwestern United States. So you can think of Arizona and California, like we mentioned. You can also think of New Mexico and sometimes Texas. Now, what are the clinical features? Well, actually, somebody can be infected and be asymptomatic. However, some patients can have symptomatic coccidioidomycosis, and that's called valley fever. And the presentation can include fever, chest pain, dyspnea, and cough. So again, not super specific. It's very similar to the other conditions we've discussed. But just like the other conditions, it can have extrapulmonary symptoms. And those would include night sweats, weight loss, erythema nodosum, and symmetric arthralgia. And if they do have symptoms, they'll usually persist for a few weeks and even months. And in the case of disseminated coccidioidomycosis, you're really worried about the CNS dissemination, so meningitis. So how do you diagnose it? Well, on chest radiography, there will be unilateral lobal infiltrate, as well as ipsilateral hilar lymphadenopathy. And that's interesting because on the other two conditions, histoplasmosis and blastomycosis, it was more diffuse and bilateral. And serologic testing should be performed, and that's to detect the coccidioides IgM or IgG antibodies. And then microscopy and cultures of the specimens that you obtain, for example, from respiratory secretions, can also be considered. So here's a microscopic slide from a patient diagnosed with coccidioidomycosis. Note the spherule that is filled with endospores. So once you've diagnosed it, how do you manage it? Well, if the patient is immunocompetent and they have a mild to moderate disease, then you don't need to prescribe anything. And that's more similar to histoplasmosis. Remember, blastomycosis, you basically treat every patient with antifungals, regardless of how mild it is. But that's not the case with coccidioidomycosis. However, you are going to want to give antifungal therapy for any of those immunocompetent patients who have severe disease. And that's fairly intuitive. You've got this patient with a severe fungal infection, you're going to want to treat it. And how do you treat that? Fluconazole or itraconazole. And again, we're referring to immunocompetent, non-pregnant patients with severe disease. And in any patient who is immunocompromised, the same is true. You can give fluconazole or itraconazole. And if there's any presence of respiratory compromise, then you're going to add amphotericin B to that regimen. So if you've got a patient with severe disease, you've chosen fluconazole for the patient, you're treating them with that, but then you realize, oh, they've got respiratory compromise. We're worried about respiratory failure. Then you're going to add amphotericin B. So now let's move on to the next category of patients. So before, I made a point of saying that those immunocompetent patients with severe disease were non-pregnant. Those patients would be given fluconazole or itraconazole. However, azoles should be avoided in pregnant patients. So if you have a pregnant patient with severe disease, then you're going to want to give amphotericin B. So now that we've covered the information, let's wrap up with a board-style question. A 35-year-old male presents to the office complaining of fatigue, chest pain, and cough. The symptoms started 3 weeks ago. His medical history contains hypertension that is controlled by medications. He is a non-smoker and only drinks alcohol on weekends. He lives in Ohio, but took a short trip to Europe last week. His temperature is 100.5 degrees Fahrenheit, blood pressure is 135/90, and heart rate is 85 beats per minute. Cardiopulmonary examination is unremarkable. Chest x-ray shows bilateral patchy infiltrates. Histopathologic evaluation of the specimen from bronchoalveolar lavage shows yeasts. What is the most likely responsible pathogen of the patient's condition? A. Aspergillus, B. Histoplasma capsulatum, C. Coccidioides immitis, or D. Pneumocystis jirovecii. Okay, so our patient has fatigue, chest pain, and cough, and that's been going on for 3 weeks. In Ohio, the place where he ordinarily lives, is a piece of information that you should pay attention to, which you've probably already thought about, like why is this location important? And then the chest x-ray shows bilateral patchy infiltrates. And we're thinking this is a fungus, obviously because yeasts were detected on the specimen, the bronchoalveolar lavage specimen. But the question is, which fungus of these options is the most likely responsible pathogen? Well, the most likely is Histoplasma capsulatum. Now remember what we discussed about pulmonary histoplasmosis. It's usually mild, and it has a presentation of fever, headache, cough, and chest pain. And then on chest radiograph, you'll see focal, patchy, or nodular infiltrates. And then lastly, histoplasma is most endemic to Ohio and nearby states. So the correct answer is B, Histoplasma capsulatum. Now let's briefly discuss the other choices. Aspergillus causes invasive aspergillosis, which most commonly affects neutropenic patients And then nodular infiltrates can be seen on X-ray, but the histopathologic evaluation of the specimen would reveal hyphae, not yeast. And in our sample, we saw yeast. So A is incorrect. Now C is incorrect because Coccidioides immitis can cause valley fever, which would present with fever, chest pain, and dyspnea. So that could apply to our patient. However, it's most endemic to the southwestern United States, like Arizona, not Ohio. Also, the chest X-ray for coccidioides would most likely be unilateral, and you would see a lobar infiltrate and ipsilateral lymphadenopathy. And again, in our patient, it was bilateral. But the most important detail that makes Coccidioides immitis unlikely is the bronchoalveolar lavage specimen, because it showed yeast. And if you recall from the beginning of this lecture, Coccidioides is one of the few dimorphic fungi, and it's the only one we discussed in this lecture, that at body temperature forms spherules, not yeast. So again, C is incorrect. Now, D is also incorrect. Pneumocystis idovecii causes pneumonia, and that can present as dyspnea, fever, and chest pain. Again, not specific, and based on that information alone, that could be true here. However, this is an opportunistic infection, and it typically affects HIV-infected patients who have a CD4 count less than 200. And our patient is immunocompetent, and his residence in Ohio further suggests histoplasma as the most likely diagnosis. So again, choice D is incorrect. And that concludes this section.